Have a look of this question. A newborn was having respiratory distress, newborn. During assessment, pediatrician sent the baby for chest x-ray after Riles tube insertion. The finding is given below. All of the following statements are correct about this condition except. Now see, what is the diagnosis in this case? Newborn with respiratory distress. And if you see this chest x-ray, what you can see, there is coiling of Riles tube. Coiling of Riles tube in stomach, and here you can see that stomach is located in thorax. So this is a classical case of congenital diaphragmatic hernia. So this is a classical case of congenital diaphragmatic hernia, which is also known as Morgagni hernia. Other name is posterolateral hernia. Posterolateral hernia. Now what is the problem in this case? See, suppose this is the thoracic cavity and this is the peritoneal cavity. Now what is the problem? Because of defective development of or failure of closure of pleuroperitoneal canal, because of failure of closure of pleuroperitoneal canal, whatever the organs are located here, these organs are herniated. So what are the organs located here? You can see the stomach is there, spleen is there, and transverse colon is there. So these organs are herniated in thorax. This is a case of congenital diaphragmatic hernia. And since these organs are herniated in the thorax, ipsilateral lung is collapsed and heart is displaced to the right side, that is known as dextrocardia. And this part of abdomen is having depression known as scaphoid abdomen. This is scaphoid abdomen. Now see the questions. Now see the options. It is more common on left side. This is correct. Bag and mask ventilation is contraindicated. That is also correct. Why? Because if you are going for bag and mask ventilation, there is collection of gas in the stomach, and this gas is going to distend stomach, and gastric distension is going to collapse the ipsilateral lung. Third, and now see the fourth option. It is characterized by triad of respiratory distress, dextrocardia, scaphoid abdomen. So this is correct. The mnemonic is RDS. The triad of congenital diaphragmatic hernia is RDS. R means respiratory distress, D means dextrocardia, S means scaphoid abdomen. But see the problem. Here in C option, most common cause of death is pulmonary hypertension. This is incorrect. What is the most common cause of death in congenital diaphragmatic hernia? The correct answer is what? It's the pulmonary hypoplasia. It's the pulmonary hypoplasia followed by pulmonary hypertension. Pulmonary hypoplasia followed by pulmonary hypertension. And this question was asked many times indirectly. Question: what's the most important prognostic factor for congenital diaphragmatic hernia? And again answer remains same. It's the pulmonary hypoplasia followed by pulmonary hypertension. So for this question, what is the correct answer? Correct answer is C. Most common cause of death is pulmonary hypoplasia, not the pulmonary hypertension. Now, how we are going to diagnose this condition? By chest x-ray. On chest x-ray, what you have seen here, there is presence of gastric bubble in the thorax, or presence of bowel in the thorax. And how we can confirm it? If we are going to insert the Riles tube, coiling will occur in stomach, and that is located in thorax. After that, after diagnosis, how we are going to plan the treatment? What is the definition of hernia? Definition of hernia is protrusion of viscus or part of viscus through the wall of its containing cavity. What is the management protocol in any case of hernia? Simple. Reduce the herniated organ back and close the defect. So here also what we are supposed to do, reduce the herniated organ back and close the defect. Whenever defect is large, generally we use mesh in cases of hernia, but here patient is a newborn or a child, and in children we are not using mesh. Why? Because with growth of child there is no growth of mesh. That's why if a large defect is there, we use prosthetic patch. So here, how we diagnose this condition? Investigation of choice for diagnosis, that is chest x-ray. And what's the treatment? Reduce the herniated organ back, reduction plus closure of defect. And for large defect prosthetic patch is used. So for large defect we use prosthetic patch. Now have a look of this question. All of the following statements are correct about Morgagni hernia. About Morgagni hernia, except it is more common on right side. Yes, Morgagni hernia is more common on right side. Most commonly herniated viscera is actually transverse colon. It's transverse colon. Most patients are asymptomatic, yes, and transabdominal route is preferred for surgical repair. That is also correct. For this question, the correct option is what? B. Now see what is Morgagni hernia. Morgagni hernia is a type of congenital hernia, congenital diaphragmatic hernia, which is also known as Larry's hernia. That's also known as Larry's hernia. It's also known as retrosternal hernia. Retrosternal hernia. Now, what's the space of Morgagni or space of Larry? The space of Morgagni or space of Larry is towards right side. Towards right side, very close to xiphoid process. So, it is towards right side, very close to xiphoid process. Via this space of Morgagni or Larry, superior epigastric vessels pass. Now, whenever there is defective development of central tendon of diaphragm, the size of defect is a bit large. And there is one organ in epigastric region. What's that? Transverse colon, which is most prone to herniate. So, most commonly herniated organ is transverse colon. Now, when transverse colon is herniated here, and if I'm sending the patient for X-ray, what I will get? Anterior mediastinal mass. But what is the good thing? And what is the clinical feature in this case? Majority of patients are asymptomatic. That's why it's diagnosed incidentally on chest X-ray, and there is anterior mediastinal mass. Again, we will apply the principle of hernia repair. What? Reduce the herniated organ back and close the defect. Here, which route is preferred? It's the transabdominal route is preferred for reduction of transverse colon. And after that, we have to close the defect. And again, like Bach-Dallek hernia, there we used prosthetic patch. Here also, we use prosthetic patch. So in this case, vessel which passes via Morgagni space, that is superior epigastric vessels. Second very important question. Most common organ herniated. Most common organ herniated. And that's transverse colon. In clinical features, most patients are asymptomatic. Again, it's diagnosed by chest X-ray, and we find what? Anterior mediastinal mass. We find anterior mediastinal mass. And what's the treatment? It's surgical repair via transabdominal route. Surgical repair via transabdominal route. So we go for surgical repair. And for large defects, we use what? Prosthetic patch. Prosthetic patch. So congenital diaphragmatic hernia, both Bogdalek as well as Morgagni, is very important, frequently asked in NEET as well as in AIMS. Nowadays, lots of questions are asked about esophageal anatomy. Have a look. Which of the following statement is not correct about esophageal anatomy? Length of upper esophageal sphincter is 4 to 5 centimeter and the upper esophageal pressure is 60 mmHg. This is correct. Length of lower esophageal sphincter 5 centimeter, pressure is 6 to 26 mmHg. This is also correct. Intra-abdominal length of lower esophageal sphincter is 1 centimeter. Actually, it is 2 centimeter. Intra-abdominal length of lower esophageal sphincter is 2 centimeter. And upper esophageal sphincter consists of distal portion of inferior pharyngeal constrictor, correct, cricopharyngeus, correct, and circular muscle of proximal esophagus, that's correct. So for this question, what is the correct answer? Correct answer is C. Correct answer is C. Why? Because intra-abdominal length of lower esophageal sphincter is actually 2 centimeter. Now see, what are the questions which are asked about esophageal anatomy? First question, what's the length of esophagus? Usually, length of esophagus is 25 centimeter. Second question, what is the extent of esophagus? Extent is from cricopharynx to G junction. So this is from cricopharynx, that is C6, to G junction, that is T11. So extent C6 to T11. Third question, what are the three narrowings usually seen on endoscopy? So from upper incisors, there are usually three narrowings on upper GI endoscopy, and how to remember, mnemonic is BALD. From upper incisor, 15 centimeter, 25 centimeter and 40 centimeter. How to remember? B means beginning. Beginning of esophagus means cricopharynx. So this is at cricopharynx. A means arch of aorta, arch of aorta, and L means left bronchus. L means left bronchus, and D means dome of diaphragm. D means dome of diaphragm. Clear? So it's beginning or cricopharynx, arch of aorta, left bronchus, dome of diaphragm. These are the three narrowings. After that, questions are asked that what are the layers which are missing? Serosa is absent or missing in esophagus. After that, another question, out of Auerbach plexus and Meissner's plexus, there is only single plexus. So which plexus is absent here? Meissner's plexus is absent. So in esophagus, there is a single plexus known as Auerbach plexus. And third very important finding, unique feature of esophagus, what? There is presence of lymphatics in lamina propria. Usually lymphatics are present in which layer? Submucosa. But here lymphatics are present in lamina propria. So important points about esophagus. First, there is absence of serosa. There is absence of Meissner's plexus. Absence of Meissner's plexus. After that, another very important point, there is presence of L in L. L in L means lymphatics in lamina propria. Lymphatics in lamina propria. After that, what is the lining of esophagus? It is stratified non-keratinized squamous epithelium. Stratified non-keratinized squamous epithelium. Now see the distribution of muscle. In upper 1/3 of esophagus, there is stratified muscle. In lower 1/3, there is exclusively smooth muscle, and in middle 1/3, there is slow transition from stratified to smooth. So these are the questions related to esophageal anatomy per se. Now we are going to discuss the esophageal sphincters. There are two esophageal sphincter, upper esophageal sphincter and lower esophageal sphincter. So see the questions related to sphincters. First, about length. How to remember the length of upper esophageal sphincter and lower esophageal sphincter? Just remember what? 5 centimeter. In both of the cases, it is 5 centimeter. After that, pressure in upper esophageal sphincter, it is 60 mmHg, and in lower esophageal sphincter, it is 6 to 26 mmHg. This question was actually asked 2 to 3 times. Third question, the intra-abdominal length of LES, lower esophageal sphincter, be careful, it is 2 centimeter. And see, this upper esophageal sphincter comprises of distal part of inferior pharyngeal constrictor, cricopharyngeus, and circular muscle of proximal esophagus. Now have a look at another question. What is the definition of incompetent LES? So see, this is lower esophageal sphincter. Now what's the normal length of lower esophageal sphincter? Normal length is 5 centimeter, and the normal intra-abdominal length is 2 centimeter. How much is the normal pressure? It is 6 to 26 mmHg. Now see the problem. What is the definition of incompetent LES? Whenever the total length is less than 2 centimeter, intra-abdominal length is less than 1 centimeter, and LES pressure is less than 6 mmHg. This is the definition of incompetent LES. And whenever there is incompetent LES, what is the problem? It leads to gastroesophageal reflux disease. So for GERD, there should be incompetent LES, and this is the definition. These are the kind of questions which are frequently asked nowadays. Okay, have a look at this question. A 55 years old male had retrosternal discomfort. Retrosternal discomfort. Be careful. Unrelated to physical exertion. If it is unrelated to physical exertion, can you see? This option is ruled out. Ischemic heart disease. Pain gets worse after lying down. Partial relief with antacids. If there is partial relief with antacids, what? Carcinoma esophagus ruled out. Achalasia cardia ruled out. Why? Because there is relief with antacids. So it means there is some kind of reflux going on. In which type of hiatus hernia there is reflux? In sliding hernia. And that's why the symptoms are better if we take antacids or PPI. So here what's the most likely diagnosis? So here the correct answer is what? Hiatus hernia. Now lots of questions are asked about what are the types of hernia, investigation of choice, and management. So have a look first. So have a look of types of hiatus hernia. This is type 1. What's the other name of type 1? It's sliding hernia. Now in this case, can you see what's happening? In sliding hernia, only G junction is herniated into thorax. Right? What happens in type 2? Can you see the G junction is in normal position, but there is herniation of what? Fundus of stomach. In type 3, can you see there is herniation of both G junction as well as fundus. And in type 4, what? It's also a type of paraesophageal hernia, where apart from herniation of fundus, some other intra-abdominal organ like bowel has been herniated. So type 1 is sliding, type 2 is true paraesophageal hernia, type 3 is mixed paraesophageal hernia. Type 2 is also known as rolling hernia, and if type 3 is mixed, it's also known as rolling plus sliding. And type 4, it's paraesophageal hernia with herniation of other intra-abdominal organ. Herniation of other intra-abdominal organ. Simple. After that, question is asked, what's the most common type? The most common type is what? sliding hernia. Second question, what's the most common type of paraesophageal hernia? The most common type of paraesophageal hernia is type 3. Now coming to the symptoms. In type 1C there is sliding of G junction, and that's why in type 1 there will be symptoms of reflux. There will be symptoms of reflux. In type 2, what? There is abdominal pain. Why there is abdominal pain? One simple logic is there. Whenever there is ischemia of any organ anywhere in the body, because of ischemia of any organ anywhere in the body, immediately patient is going to perceive pain at that particular region. When fundus is herniated, there is ischemia, and because of this ischemia, patient will be having pain. What will be the symptom in type 3? Both symptoms of reflux plus pain. And type 4, there is abdominal pain plus increased risk of complications like strangulation. How we are going to diagnose it? It's diagnosed by barium studies, usually diagnosed by barium swallow. And what's the treatment? It's the laparoscopic hiatus hernia repair. Via which route we are performing the repair? It's performed via transabdominal route. So it's transabdominal laparoscopic hiatus hernia repair. In this question, a 35 years old lady presented with retrosternal burning pain, epigastric pain and regurgitation for 6 years. Now be careful, retrosternal burning pain, epigastric pain and regurgitation. So retrosternal burning pain, epigastric pain and regurgitation. Actually, this is the classical triad of symptoms for GERD. Classical triad of symptoms for GERD. Now question, which of the following is most preferred treatment option? So this is the classical case of gastroesophageal reflux disease, and for this what is the most preferred treatment option? And that is laparoscopic Nissen's fundoplication. Now see, actually speaking, in gastroesophageal reflux disease, what's happening? Because of incompetent ileus, there is reflux of gastric content into esophagus. And because of this reflux, what will happen? Can you see? There is GERD. So there is reflux esophagitis. After that, what happens? There is ulceration. After that, there is fibrosis. After that, there is stricture. After that, over a long duration of time, sometimes the squamous epithelium of esophagus is replaced by columnar, and this is known as what? Columnar metaplasia. So this is known as columnar metaplasia, and this columnar metaplasia is also known as Barrett's. This is also known as Barrett's esophagus. Clear? And this Barrett's esophagus increases the risk of adenocarcinoma. Now, what are the clinical features? The classical triad of symptoms: retrosternal burning pain, epigastric pain, regurgitation. After that, what is the investigation of choice for diagnosis? It's the 24 hours pH monitoring. And on this 24 hours pH monitoring, we calculate one score. What's the name of that score? It's Demester's score. Normally, how much it should be? It should be less than 14.7. It means in case of GERD, Demester's score is more than 14.7. It's more than 14.7. Now, what are the treatment options? See, in this case, we give double dose of PPI apart from lifestyle modification and dietary modification. Since fatty food, smoking, coffee which contains caffeine, all these decreases LES pressure. And because of decrease of LES pressure, there is reflux. That's why in lifestyle modification, patient is advised for cessation of smoking, low fat diet, low intake of caffeine or no intake of coffee or caffeine. For symptomatic relief, we give double dose of PPI, proton pump inhibitors. But be careful, any patient who is having life expectancy of more than 10 years, in all those cases we go for fundoplication to prevent GRD. And what is the preferred fundoplication? It's the laparoscopic Nissen's fundoplication. So in this question, all the four options are used in the management. But what is the preferred treatment option? It's the laparoscopic Nissen's fundoplication. Now see this question. What's the name of this fundoplication? Now see the normal stomach. And in this case, can you see what is happening? Some part of fundus of stomach has been taken from behind of esophagus, and some part is taken from front, and after that it is plicated. So this is 360-degree plication of fundus around esophagus. 360-degree plication of fundus around esophagus. So this is 360-degree fundoplication, and this is actually what Nissen's fundoplication. There are various types of fundoplications which are asked. So have a look. What are the various types of fundoplication? To understand fundoplication, first you have to imagine something. So have a look. Suppose this is esophagus and this is stomach. I'm going to take a section of esophagus. After that, this is the esophagus. I'm going to divide this esophagus into axes. Two axes. After that, I'm taking fundus and I'm going to plicate 1/4 of esophagus. If only 1/4 of esophagus is plicated, this is known as Watson. This is anterior and this is posterior. So Watson fundoplication is how much? 90-degree anterior. Now see, if I'm taking fundus from anterior direction and going to cover half of esophagus, so this is door fundoplication, 180-degree anterior. After that, have a look of this one. This is toupee, and toupee is how much? Toupee is 270-degree posterior. After that, similarly, there is a Belsey Mark 4. This is Belsey Mark 4, and Belsey Mark 4 is also 270-degree, but be careful, it is anterior. And if we are going for 360-degree fundoplication, that is Nissen's fundoplication, and that's 360-degree. So on the basis of images provided in the exam, how you can easily crack the question, have a look. So if you see this question, here you can find out that there is 360-degree fundoplication, and this is what? Nissen's. Indoor, can you see? Indoor, only anterior part, half of esophagus is covered by fundus, only anterior part. So this is what? Door, and that is 180-degree anterior. Now can you see this is toupee, and what? 3/4 is covered almost from posterior direction. So this is what? 270-degree posterior. And the Belsey Mark 4 is 270-degree anterior fundoplication. Nissen's is 360-degree, and the Watson is 90-degree anterior. So all these are questions which are very important nowadays asked in exam. In this question, a 40 years old female presented to OPD with complaints of retrosternal heartburn, dysphagia more for liquids, and occasional aspiration. Retrosternal heartburn, dysphagia, be careful, more for liquids as compared to solids, and occasional aspiration. Barium swallow is given below. Which of the following statement is false about this condition? So first, see what is the finding in the barium swallow. Here you can see there is narrowing of LES, and beyond this point the barium is not going into stomach. So what? There is, in this case, can you see, there is absence of LES relaxation. Absence of LES relaxation. And what's the name of this condition? This is known as Achalasia cardia. This is known as Achalasia cardia. What is the name of this finding? Classically, this is looking like bird beak. Classically. So this is bird beak or pencil tip. So this is having bird beak or pencil tip appearance. Some books also describe it as rat tail appearance. Some books describe it as rat tail appearance. Be careful. Some books says that rat tail appearance is also seen in carcinoma esophagus, and actually speaking, in carcinoma esophagus there is rat tail filling defects. So here there is rat tail appearance, bird beak appearance, pencil tip appearance, rat tail appearance. What's the problem in achalasia cardia? In achalasia cardia there is absence of Ellis relaxation. What's the pathophysiology? I told you there is a single plexus in esophagus. Which one? Orbac. In Orbac plexus, there are two kinds of neurons. One is stimulatory and one is inhibitory. What's the function of Orbac plexus? It helps in peristalsis. Stimulatory neurons function contraction, inhibitory relaxation. So there is selective absence of which kind of neurons? So there is selective loss or absence of inhibitory neurons. That's why there is LES contraction only, there is no relaxation. So what happens in this case? There is just LES contraction, absence of LES relaxation. And that's why after meals most of the food is collected into esophagus. Esophagus is filled with food and liquid content, and because of this patient is having what? Regurgitation. There is aspiration. Some patients are also having nocturnal asthma or cough, and there is weight loss because nothing is going into stomach. So see the question. It is due to lack of inhibitory neurons in Orbac plexus. This is correct. Characterized by classical triad of dysphagia, regurgitation and weight loss. This is also correct. Why? Can you see? This is esophagus. This is stomach. There is absence of LES relaxation. So the food, liquid content, whatever patient is going to take, everything is collected where? In the esophagus. That's why there is increased risk of regurgitation. There is increased risk of aspiration, and because of this aspiration there is pneumonitis, and there is increased risk of lung abscess. And here, because of this ongoing chronic inflammation, there is increased risk of squamous cell carcinoma. Nothing is going into stomach or very little content is entering into stomach. That's why this patient is having what? Weight loss. Now, this is a motility disorder of esophagus. Achalasia cardia. Achalasia cardia is most common motility disorder of esophagus. It's most common hypomotility disorder of esophagus. So for motility disorders of esophagus, what's the investigation of choice for diagnosis? It's the manometry. Investigation of choice for diagnosis is manometry. And what's the treatment? It's the Heller's cardiomyotomy, which is the treatment of choice. By the way, what are the other treatment options? LES is a smooth muscle. It's not able to relax. So we are giving what? Nitrates and calcium channel blockers for relaxation. Second, we are going for forceful dilatation of LES with the help of dilator, that is known as bougie or balloon. We can inject Botox, botulinum toxin, because Botox inhibit acetylcholine release and it prevents the contraction. Means it leads to relaxation. But the treatment of choice is what? Heller's cardiomyotomy, and that's performed laparoscopically. So here, what is the correct answer? Barium swallow is gold standard investigation. That's incorrect. Investigation of choice for diagnosis is what? It's manometry. And if we are performing barium swallow, what are the appearances? We get bird beak, pencil tip, rat tail appearance. So for this question, correct answer is C. See this question. A 40 years old male presented with chest pain, which mimics angina and dysphagia. Chest pain very similar to angina and dysphagia. The barium swallow finding is given below. Which of the following statement is not correct about this condition? Now can you see what's the name of this appearance? This is known as corkscrew appearance, also known as rosary bead appearance, also known as pseudo diverticular appearance. So the names corkscrew appearance, rosary bead appearance, pseudo-diverticular appearance, and you must be knowing all these appearances are seen in which condition? It's seen in diffuse esophageal spasm. So it is seen in diffuse esophageal spasm. Now, what is the problem in this case? It is because of tertiary contraction. Because of tertiary contraction of esophagus. Now see, this is esophagus. These are the blood vessels which are going to supply the esophagus. You must be knowing that esophagus is not having its own blood supply. The region via which it is going to travel, it receives the blood supply from that region. That's why in cervical region, it is receiving blood supply from inferior thyroid artery. In thorax upper part, it is getting supply from bronchial arteries. In lower part, directly from aorta, near diaphragm via inferior phrenic artery, and near G junction via left gastric artery. So these are the arteries which are going to supply esophagus. These arteries penetrate esophagus at right angle, the muscularis, and then they supply. In tertiary contraction, there is spasm, and because of this spasm, its blood supply is cut off. So there is spasm, and because of this spasm, there is ischemia, and because of this ischemia, there is chest pain, and dysphagia. Chest pain and dysphagia. Now, in this case, there is spasm. If there is spasm, we have to relax the spasm. So how we are going to relax the spasm? Again by nitrates or by calcium channel blockers. Sometimes we go for dilatation also. And I told you, for motility disorders, investigation of choice for diagnosis is what? Manometry. So see the question options. First, caused by secondary contraction of esophagus. This is incorrect. It's the tertiary. Symptoms are pronounced during times of heightened emotional stress. This is also correct. Classical manometric findings are simultaneous multi-peaked contraction of amplitude more than 120 mmHg, duration more than 2.5 seconds. This is correct. This is asked in exam. Amplitude more than 120 mmHg, duration more than 2.5 seconds. And mainstay of treatment is non-surgical, mainly by nitrates or calcium channel blockers or endoscopic intervention, that is bougie dilatation. And if we are sending the patient for barium swallow, what kind of appearance is seen? It's corkscrew, rosary bead or pseudo diverticular appearance. Now have a look of this question. All of the following statements are correct about motility disorders of esophagus except first, most common motility disorder of esophagus is achalasia. That is correct. And it's the most common hypomotility disorder of esophagus. Nutcracker's esophagus is most common hypermotility disorder. Most common hypermotility disorder of esophagus. So you can see first option is correct. Second option, most common hypermotility disorder of esophagus is Nutcracker's esophagus. This is also correct. Components of AAA syndrome. This was asked in a latest exam. AAA syndrome is also known as Algrove's disease. And the components are achalasia, alacrima, absence of tears, alacrima, and ACTH resistant adrenal insufficiency. So be careful. At the place of alacrima here, alopecia is mentioned. So this is incorrect. And for hypertensive LES, when the LES pressure is higher, hypertensive LES, laparoscopic modified Heller's esophagomyotomy, that is also known as Heller's cardiomyotomy is the operation of choice. This is also correct. So see, all of the following statements are correct except, so for this question, the correct answer is what? C. The components of AAA syndrome or Algroove's disease are A. Achalasia, A. lacrima, and ACTH resistant adrenal insufficiency. See this question, a 60 years old diabetic male, can you see? 60 years old diabetic male presented to medicine OPD with signs and symptoms of lung abscess. There is lung abscess. On further evaluation, he was found to have dysphagia, gurgling noise after eating, and halitosis. Barium swallow finding if is given below. Which of the following is the treatment of choice for this condition? So you must be knowing what's the diagnosis in this case. This patient is having Zenker's diverticulum. Zenker's diverticulum. What is the cause? In this case, there is herniation of mucosa and submucosa via Killian's dehiscence. So what's that Killian's dehiscence? Have a look. Now in this case, you can see there are oblique fibers of thyropharynges and there is transverse fibers of cricopharynges. In between, there is a dehiscence, and this dehiscence is known as what? Killian's dehiscence. Via this Killian's dehiscence, there is herniation of only mucosa and submucosa, and that's known as what? Zenker's diverticulum. So this is Zenker's diverticulum. So be careful, it's acquired, it's false, more common in elderly, more common in diabetic patients. Now what are the symptoms? In this case, there is dysphagia, there is gurgling sound, there is halitosis, and whatever the content, can you see? This is the diverticula. Whatever the content is collected here, at the time of sleep or when patient is going to lie down, there is aspiration. And because of this aspiration, what's the problem? There is pneumonitis and it leads to lung abscess. Pneumonitis and it leads to lung abscess. Right? So question is asked, what's the most common complication of Zenker's diverticulum? It's lung abscess. Second, because of chronic or ongoing inflammation in the diverticula, it increases the risk of squamous cell carcinoma. What is the investigation of choice for diagnosis? It's barium swallow, and you have seen this kind of appearance is seen, which is given in the question. Now coming to the treatment. The various treatment options are given below. All these are treatment options. We go for diverticulectomy, means excision of diverticula. We go for diverticulopexy, means you can see this is the diverticulum. In diverticulopexy, I'm taking the diverticula posteriorly and going to fix it with prevertebral fascia. So can you see? It's fixed like this. So this is diverticulopexy. And what is the treatment of choice? We go for cricopharyngeal myotomy with diverticulopexy. There is another alternative in which there is endoscopic stapling of the wall. Endoscopic stapling or excision of the wall between diverticula and esophagus, and that's why it's known as diverticuloesophagostomy. This is diverticuloesophagostomy, and what's the name of this procedure? It's the Dohel-Mann procedure. Dohel-Mann procedure. Now see the question. So in this case of Zenker's diverticulum, what's the treatment of choice? The treatment of choice is cricopharyngeal myotomy plus diverticulopexy. Rest of the options are also treatment options for this diverticulum. So correct answer is C. This question was asked in a latest exam that Dohel-Mann surgery is in Zenker's diverticulum is. It is endoscopic stapling of septum. Now see how this Dohel-Mann surgery is performed. So in this case, what you can see that This is the wall between, this is the wall of diverticulum and esophagus, and whenever we are going to fire the stapler, what happens? This wall is removed. So what? Usually we perform what? Endoscopic stapling. Sometimes we also perform surgical excision, laser excision, but be careful. For larger diverticula, preferred treatment option is what? In Dohleman procedure is endoscopic stapling. And that's why, what is the name? This is diverticula and this is esophagus. So the alternative name of this procedure is diverticulo esophagostomy. Correct answer for this question is A. Okay, before discussing this question, have a look of esophageal diverticulars. Various types of esophageal diverticulars. Now if you see this diagram, you can see that this is Zenker's diverticulum, and Zenker's diverticulum is the most common type of esophageal diverticulum. It is a false diverticulum because it contains only mucosa and submucosa. What is the other name? It is also known as hypopharyngeal diverticulum. Now see this second one. This is the diaphragm, and there is one diverticulum located just above diaphragm. So what's the name of this diverticulum? This is epiphrenic diverticulum. Diverticulum located just above diaphragm, epiphrenic diverticulum. Now see this one, parabronchial, also known as traction diverticulum, also known as mid-esophageal. Be careful, it's located in the middle part of esophagus. So mid-esophageal diverticulum. Names: parabronchial, also known as traction diverticulum, also known as mid-esophageal diverticulum. Most of esophageal diverticulars are false. Only exception is this traction. Why? Can you see? This is esophagus. Now, there are certain patients who are having tuberculosis or histoplasmosis. Because of tuberculosis or histoplasmosis, there is mediastinal lymphadenopathy. Because of inflammation, there is fibrosis. And if there is fibrosis, what happens? There is traction on the esophageal wall. And if there is traction on the esophageal wall, all the three layers, mucosa, submucosa and muscularis, are pulled outward. There is traction outwards, and that's why what? This is the only diverticulum which is true. So mid-esophageal diverticulum is true. Epiphrenic is also false. Zenker's is also false. Mid-esophageal diverticulum is true. So see the question. In this question, which of the following statement is correct about esophageal diverticula? Most of esophageal diverticulars are false. So this is incorrect. Traction diverticula is false diverticula. It's actually true diverticula. Epiphrenic diverticula is located just below diaphragm. Actually, it is located just above diaphragm. So obviously, by principle of exclusion, what is the correct answer? It's the Killian-Jamison diverticula that is located just below cricopharyngeus. Now here we are going to compare Zenker's diverticulum and Killian-Jamison diverticulum. Can you see? This is Zenker's diverticulum. If you see, this muscle is cricopharyngeus, this is thyropharyngeus, and this is Killian's dehiscence. Why are these Killian's dehiscence? There is herniation of mucosa submucosa, that is Zenker's. If you see the location, Zenker's diverticulum is located above cricopharyngeus. But if you see this Killian-Jamison diverticulum, can you see? It's located below cricopharynx. Usually Zenker's diverticulum is in midline. When the size increases, it goes on left side. But if you see this Killian-Jamison diverticulum, actually it is placed laterally. So it is located below cricopharynx and it is placed laterally. Can you see the diagram here? This is Zenker's, and can you see this is the Killian-Jamison diverticulum. Now here you can see this is Zenker's, and here this is placed laterally. This is Killian-Jamison. So Killian-Jamison diverticulum, mostly asymptomatic, located below cricopharyngeus and placed laterally. So if you see the question again, Killian-Jamison diverticula is located just below cricopharyngeus. This is the correct answer. So for this question, the correct answer is D. This is one of the commonly asked question in most of the exam. Almost every year, this kind of question is asked. Almost every year. So see the question. A 40 years old American patient presented to medicine OPD with long history of heartburn, dyspepsia. He was taking PPI for the last 10 years for these symptoms. Upper GI endoscopy was performed and the findings are given below. Which of the following statement is false about this condition? Now you can easily make out what's the diagnosis. This patient is having GERD for last 10 years and this patient was taking PPI and there was symptomatic relief. When the endoscopy is being performed, can you see this pale mucosa? This is actually squamous epithelium. This is squamous epithelium. And can you see this pink velvety mucosa? Pink velvety mucosa. This pink velvety epithelium or mucosa is what? It's intestinal columnar epithelium. So this pink velvety mucosa or epithelium is intestinal columnar epithelium, and you know it's a case of columnar metaplasia because of GERD. And what's the name? This is Barrett's. This is Barrett's esophagus. So about Barrett's esophagus, which of the following statements are false? Distal squamous mucosa is replaced by intestinalized columnar epithelium. This is correct answer. This is correct option. Columnar epithelium is resistant to acidic injury. This option is also correct. See, squamous epithelium is not resistant. That's why when there is ongoing GERD or reflux, that's why it's the body's protective response to replace the sensitive squamous epithelium by acid resistant columnar epithelium. So B is also correct. For diagnosis of this condition, what is the investigation of choice? Endoscopy plus biopsy. On endoscopy, the appearance should be presence of pink velvety intestinalized columnar epithelium. On biopsy, there should be presence of goblet cells. Be careful. Both endoscopy plus biopsy is investigation of choice for diagnosis. How many biopsies are taken? Be careful. We take 8 random biopsies. 8 random biopsies, not the 6 random biopsies. So this option is incorrect. And just like any other case of reflux, we are going to treat this patient by anti-reflux therapy with continuous follow-up or surveillance by upper GI endoscopy. So for this question, what's the correct answer? It is C, because we take 8 random biopsies, not the 6 random biopsies. Now see this question, which of the following is not a risk factor? Squamous cell carcinoma esophagus. Now let me tell you 2-3 basic principles. Suppose some organ is having squamous epithelium. If some organ is having squamous epithelium, usually the malignancy arising, which is carcinoma arising from epithelium. So if carcinoma is arising in that organ, it will be squamous cell carcinoma usually. So have a look. In oral cavity, there is squamous epithelium. Malignancy is squamous cell carcinoma. Oropharynx, nasopharynx, squamous cell carcinoma. Esophagus, squamous cell carcinoma. Anal canal, squamous cell carcinoma. Cervix, squamous cell carcinoma. Now see the bladder, ureter and renal pelvis. In renal pelvis, ureter and bladder, epithelium is transitional epithelium. So what is the malignancy? It is transitional cell carcinoma. And if the epithelium is columnar, what is the malignancy? Adenocarcinoma. Example, stomach, columnar epithelium, adenocarcinoma. Small intestine, colon, rectum, columnar epithelium, adenocarcinoma. Malignancies arising from gland like liver, gallbladder, pancreas, breast, thyroid, all these are glands. And from all these, what is the most common type of malignancy? Adenocarcinoma. After that, 2-3 basic points. It is seen usually that for squamous cell carcinoma, generally squamous cell carcinoma is more common in low socioeconomic status usually, and adenocarcinoma is usually more common in high socioeconomic status. One of the risk factor for squamous cell carcinoma, like for oral cavity, for carcinoma esophagus, carcinoma anal canal, carcinoma cervix, carcinoma penis, for all these, one common risk factor is there, and that is HPV infection, human papillomavirus infection, strain 16, 18, 31, 33. For adenocarcinoma, obesity oblique high fat diet is a risk factor, usually. Now, one common exception, see carcinoma stomach. Carcinoma stomach is adenocarcinoma, but it is more common in low socioeconomic status. Why? Because people of low socioeconomic status consume water which is not of good quality, contaminated with bacteria, HPV. The quality of food they eat is not that good, and method of preservation used is not good. That's why in low socioeconomic status there is increased risk of H. pylori infection. So that's why it's more common in low socioeconomic status. Usually, squamous cell carcinoma more common in low socioeconomic status, adenocarcinoma more common in high socioeconomic status. So see, for this question, which of the following is not a risk factor? Alcohol is a risk factor, caustic injuries are a risk factor, HPV infection is a risk factor, obesity is not a risk factor. Obesity is a risk factor for adenocarcinoma esophagus. So have a look of list of risk factors for squamous cell and adenocarcinoma. So here you can see the risk factors for squamous cell carcinoma are alcohol, smoking, intake of nitrates, nitrites, nitrosamines, smoked opiates, and fungal toxin. After that, if there is mucosal damage because of chronic achalasia cardia, caustic ingestion, ingestion of hot liquids for long duration, radiation-induced strictures, Plummer-Vinson syndrome, Tylosis palmaris et plantaris, HPV, strain 16, 18, 31, 33, esophageal diverticula, especially which one is most common? Zenker's, bulimia nervosa, and deficiency of MOSA. Mnemonic is MOSA, molybdenum, zinc, and vitamin A. Directly or indirectly, the risk factor for adenocarcinoma is related to GERD. So here you can see GERD. Obesity increases the risk of GERD. Diet high in animal protein and cholesterol. LES is decreased, indirectly causing GERD. And in scleroderma, there is smooth muscle atrophy. LES is smooth muscle. So if there is atrophy, what happens? LES is relaxed. And if LES is relaxed, what will happen? There is GERD, and that is also a risk factor. And usually for adenocarcinoma, diet deficient in fruits and vegetables are the risk factors. So this is the complete list of risk factors for squamous cell carcinoma and adenocarcinoma. See this question, a 60 years old male came to surgery OPD with symptoms of dysphagia and weight loss. The barium swallow finding is given below, and which of the following statement is correct? Correct about this condition. Now if you see what's the problem in this case, can you see this is actually esophagus, and what is the problem? Can you see this is the pathology. Now can you see there is irregular lesion, and what is the appearance? It looks like apple core appearance. So what's the diagnosis on the basis of this appearance? It's carcinoma esophagus. So see this simple diagram, this is esophagus, this is stomach. In this there is a malignancy which is going to compromise the lumen, and because of this compromised lumen, what is the problem? Most common symptom is dysphagia, and there is weight loss because of malignancy and because of this obstruction, dysphagia. What kind of dysphagia is there? There is progressive dysphagia, means initially it is two solids, followed by semi-solids, and then by liquids. So it is progressive dysphagia followed by weight loss. Sometimes what happens, there is a communication between this organ. What's this organ? This is trachea. Sometimes this malignancy is going to infiltrate trachea and there is a communication. This is known as tracheoesophageal fistula. If there is fistula, because of this, whenever patient is going to swallow anything, immediately patient will be having choking, coughing, cyanosis and dyspnea. All these are findings suggestive of malignant tracheoesophageal fistula. Now, what's the first investigation done in a suspected case of carcinoma esophagus? First investigation, it's the barium swallow. And what kind of appearance? This apple core appearance is seen. Be careful, apple core appearance on barium swallow is seen in carcinoma esophagus, but apple core appearance on barium enema is seen in carcinoma colon. That's why apple core appearance is not specific for carcinoma esophagus. It can be seen in any intraluminal malignancy, on swallow in carcinoma esophagus, on barium enema, carcinoma colon. What is the chemotherapy regimen given? The regimen is ECF, that is epirubicin, cisplatin and 5-fluorouracil. The same regimen, ECF regimen, is also given in carcinoma stomach. Okay. What is the investigation of choice for staging? It is endoscopic ultrasound. And if the lumen is obstructed, you cannot put the probe, endoscopic ultrasound probe. In that case, it's the CCT. And for distant metastasis, what's the investigation of choice for diagnosis? Distant metastasis, it is PET scan. Clear? So see the options. Overall, what's the most common site of carcinoma esophagus? Overall, it's the middle 1/3. Most common type of carcinoma esophagus worldwide is squamous. In Western countries is adenocarcinoma. Most common site of squamous cell carcinoma, middle 1/3. Adenocarcinoma, lower 1/3. And if a simple question is asked, overall what's the most common site? It's the middle 1/3. So see, this option is incorrect. Chemotherapy regimen is cisplatin plus 5-FU. This is incorrect. It is actually epirubicin, cisplatin, 5-FU. Endoscopic ultrasound is investigation of choice for staging of carcinoma esophagus. This is correct. Prognosis is better for tumors of cervical esophagus and tumors located at G junction as compared to thoracic esophagus. But what? In this option, it's just opposite. Prognosis is better for tumors of thoracic esophagus. This is incorrect. Prognosis is better for cervical esophagus malignancy and malignancies located at G junction. So for this question, what is the correct answer? It is C, and that is endoscopic ultrasound is investigation of choice for staging of carcinoma esophagus. Another question which is frequently asked. What? That what is the most important prognostic factor in most of the malignancies? It is stage. Except Wilms tumor, in Wilms tumor it's histology followed by stage, and in soft tissue sarcoma it's the tumor grade. Now in whole GI malignancy from esophagus till rectum, staging is mainly based on one parameter, T stage, and that is what? Depth of penetration. So by any investigation, if you can assess the depth, what? That investigation will be investigation of choice. That's why for carcinoma esophagus, for carcinoma stomach, investigation of choice for staging, T staging, is endoscopic ultrasound. Similarly, for carcinoma rectum, we are performing it from below, and that is known as transrectal ultrasound. So for carcinoma rectum, investigation of choice for T staging, what? T staging of carcinoma rectum is what? Transrectal ultrasound. That's why indirectly a question is asked, what's the most important prognostic factor in carcinoma esophagus? It's stage. And if it's not mentioned, sometimes they mention depth of penetration. So if stage is not mentioned, it is depth of penetration. See this question. All of the following statements are true about replacement conduits after esophagectomy except. Now what is the meaning of replacement conduit? Have a look. This is esophagus and this is stomach. Usually in carcinoma esophagus we perform esophagectomy. How much margin we take? 10 centimeter. This is the maximum margin. Why we take 10 centimeter margin in carcinoma esophagus? Because there is L in L. I told you lymphatics are there in lamina propria, and because of that there is extensive spread. So we take 10 centimeter margin. So when we take 10 centimeter margin, usually we perform the esophagectomy. After esophagectomy, what? Some part of cervical esophagus is left, and this is the stomach which is left. After that, we have to maintain the continuity of GIT, so we pull the stomach up. So what? We take the stomach up in the cervical or thoracic region, and we perform this kind of anastomosis that is known as cervical esophagogastric anastomosis. Now see, if we take stomach, see the question. What is the blood supply of stomach? This is left gastric, this is right gastric, this is left gastroepiploic, this is right gastroepiploic artery. Now we have to divide. Here you can see we have to divide left gastric and left gastroepiploic and short gastric vessels so that we can pull the stomach up. So we make a tube of stomach and we take it up in the cervical region. Question is asked, this gastric conduit is based on which artery? This was asked many times. So it is based on right gastric artery plus right gastroepiploic artery. Gastric conduit. Preferred conduit is gastric conduit or stomach. After that, esophagus is the narrowest tube of GIT. Its diameter is almost similar to left colon. That's why the second alternative is left colon. And if you are taking left colon, it is based on left colic artery. Third alternative is jejunum, which is based on jejunal arteries, which are the branches of superior mesenteric artery. Now, esophagus passes via posterior mediastinum. So after esophagectomy, the preferred route, shortest route is again posterior mediastinum. So via the same route, we take the conduit up and we perform the anastomosis. So see the question. Ideal replacement for the esophagus after esophagectomy is stomach, correct? Gastric conduit is based on right gastric and right gastroepiploic artery, correct? Colonic conduit is based on left colic artery, correct? Anterior mediastinal route is preferred. That's incorrect. It's actually the posterior mediastinal route. So for this question, what's the correct answer? It's D. See this question, which of the following statement is correct about esophagectomy? There are three types of esophagectomy which are performed usually, and the questions are asked about these. One is Ivor-Lewis operation, second is Oringer transhiatal esophagectomy, and third is Makion en-bloc esophagectomy. Now see, midline laparotomy followed by right-sided thoracotomy is performed in Ivor-Lewis. See, this is the abdomen and this is the thorax. Now here you can see this is the esophagus. In this case, how we perform the surgery? In Ivor-Lewis operation, first we perform laparotomy and after that we perform the dissection around esophagus near hiatus where it enters into diaphragm. Second incision is thoracotomy and we perform the dissection around esophagus. Clear? So this is Ivor-Lewis operation. What we do in cases of Oringer transhiatal esophagectomy? In this case, you see this is esophagus, this is stomach. First we perform laparotomy. After that we perform dissection around hiatus. Then blindly we insert the hand inside thorax and we perform the dissection around esophagus. And then via cervical incision, we excise the esophagus, we remove the esophagus, pull the stomach up and we perform esophagogastric anastomosis. What is done in Machion? These two are same, but the first incision is what? Thoracotomy. In Machion, first thoracotomy is performed. Under direct vision, esophagus is dissected. Then we perform laparotomy and then we go for cervical incision. So see the question. Midline laparotomy followed by right-sided thoracotomy is performed in Ivor Lewis. Correct. Oringer transhiatal esophagectomy, most commonly performed procedure for carcinoma esophagus. This is correct. Right-sided thoracotomy followed by midline laparotomy followed by cervical incision done in Machion esophagectomy. This is correct. So in this question, correct answer is what? D. All of the above. All of the above. All three options are correct. Have a look of this question. A 40 years old male presented to OPD with dysphagia. The barium swallow finding is given below. Which of the following statement is not correct about this condition? Now what is the diagnosis? On the basis of this barium swallow finding, you can see that there is smooth punched out filling defect. What is the cause of this smooth punched out filling defect? The cause is some benign tumor, and that is what? Leiomyoma. Leiomyoma is the most common benign tumor of esophagus. Now what is the problem? If you can see this is esophagus. Whenever there is leiomyoma, whenever it is going to compromise the lumen, because of luminal compromise, usually when 2/3 of lumen is compromised, the patient will start having dysphagia. If the leiomyoma is small, patient might be asymptomatic. Because of this, if we are going for barium swallow, what kind of finding is seen? This kind of finding is seen. Clear? And this is known as what? Smooth punched out filling defect. Now how we are going to diagnose it? Barium swallow. Endoscopy can be performed, but endoscopic biopsy is contraindicated. Why? Because if you are going to perform biopsy, what will happen? There is formation of adhesion between the tumor and the mucosa. The treatment of choice is enucleation. So when we are going to attempt the enucleation, there is perforation of mucosa. That's why endoscopic biopsy is contraindicated. So see the question. This leiomyoma is most common benign esophageal tumor. This is correct. It's mostly located in lower 2/3 of esophagus. This is also correct. Endoscopy with biopsy is investigation of choice. This is incorrect. Endoscopic biopsy is contraindicated and enucleation is the treatment of choice. This is correct. So for this question, the correct answer is C. One question is asked in surgery that enucleation is performed for benign tumors or for malignant tumors. So it's for benign tumor. What are those tumors in surgery where we perform enucleation? So have a look. This enucleation is performed for hemangioma liver. It is performed for hemangioma liver. Second, leiomyoma esophagus. Leiomyoma esophagus. Third, insulinoma. Insulinoma involving head of pancreas. Involving head of pancreas. And chyliolymphatic cyst. Chyliolymphatic cyst. So in these four conditions, the treatment of choice is what? Enucleation. Now see this question. All of the following statements are correct about dysphagia lusoria. So what is dysphagia lusoria? It's the dysphagia caused by some kind of vascular abnormality because of either vascular rings or pulmonary slings. Now see this question. All of the following statements are correct about dysphagia lusoria except. What is dysphagia lusoria? Dysphagia, disorder of swallowing caused by vascular anomalies. Usually these are congenital anomalies. So there are vascular rings and pulmonary slings. This vascular ring and pulmonary sling This is responsible for compression of esophagus, and because of compression of esophagus, there is dysphagia. So have a look. So this is the condition known as dysphagia lusoria. Here you can see that there is aberrant right subclavian artery, and this aberrant right subclavian artery is arising from descending thoracic aorta, descending aorta. At the site of its origin, sometimes there is a diverticulum. At the site of its origin, sometimes there is diverticulum, and that is known as COMLEX diverticulum. At the site of origin of aberrant right subclavian artery, there is a diverticulum known as COMLEX diverticulum. Now can you see, this right subclavian artery is arising from descending aorta, can you see, and then it is passing behind esophagus. Since it is passing behind esophagus, it is going to compress the esophagus. So it is going behind esophagus, going to compress esophagus. That's why there is dysphagia. Now it's a vascular anomaly. That's why it can be easily diagnosed by either angiography or HRCT. Now see the question. All of the following statements are correct about dysphagia lusoria except most common anomaly responsible is right subclavian artery arising from descending aorta. This is correct. Most patient present with dysphagia, correct, because there is compression of esophagus and the name is dysphagia lusoria. An aberrant right subclavian artery can be associated with COMLEX diverticulum. This is frequently asked question. Investigation of choice for diagnosis is barium swallow. This is incorrect because it's usually diagnosed by either angiography or HRCT. So for this question, the correct answer is D. See this question, which of the following is not true about Boerhaave syndrome? Before discussing Boerhaave syndrome, I want to discuss esophageal perforation. There are two kinds of esophageal perforation. One is iatrogenic perforation and second is spontaneous esophageal perforation. Iatrogenic, the most common cause of esophageal perforation is iatrogenic. Iatrogenic means during which investigation? When we perform endoscopy. Now see, whenever you are performing endoscopy and endoscopy is inserted, which part of esophagus is prone to get perforated? It's the cricopharynx. That's the narrowest part, diameter is 1.5 centimeter. Which wall of cricopharynx? Obviously, posterior wall. So can you see? It's the posterior wall of cricopharynx which is most commonly perforated. Most common cause, iatrogenic during endoscopy. What is spontaneous esophageal perforation? Suppose patient is having forceful vomiting and patient vomited against closed glottis. There is very high pressure in stomach which is transmitted into esophagus. And because of this high pressure transmission into esophagus is going to perforate at the weakest part, and that is lower or distal part of esophagus along left posterolateral direction. Now see this diagram. This spontaneous esophageal perforation is known as what? Boerhaave syndrome. Now see, if there is perforation when the patient vomited, there is forceful vomiting, whatever the content was there in stomach, that is going to enter into mediastinum. And because of this, what will happen? Patient will be having severe mediastinitis. Patient will be having thoracic pain, vomiting, and cervical subcutaneous emphysema. The name of this triad is Mackler's triad. Name of this triad is Mackler's triad. What are the components? Thoracic pain, vomiting, and cervical subcutaneous emphysema. What is the investigation of choice? It's the contrast esophagogram. We can use barium also. We can use water soluble contrast also, that is gastrographin, but be careful. Preferred is water soluble contrast. So it's the water soluble contrast esophagogram which is the investigation of choice. Now treatment, the golden period of treatment is within first 24 hours. If the patient is coming within first 24 hours, that is the golden period for primary repair. But if patient comes after 24 hours, what? There is high morbidity and mortality. So see the question. Most common site of, first question, which of the following is not true about Boerhaave syndrome? Most common site of rupture is left posterolateral side of distal esophagus. Correct? Characterized by macular striate of thoracic pain, vomiting, and cervical subcutaneous emphysema. Correct? Water soluble contrast esophagogram preferred over barium swallow. Correct? Golden period for primary closure of esophageal perforation is first 6 hours. Actually, it's first 24 hours. So for this question, what's the correct answer? It is D.